Hi, my name is Hannah. I'm a nursing student at ISU. I'm going to be assessing your heart and lungs today. Are you having any shortness of breath or chest pain at this time?
No.
Any history of cardiac issues, asthma, smoking?
No.
I'm going to start on the back by taking a look at your skin. So over here, we're going to be looking for skin distribution. So you can come over here, and we're looking for turgor by kind of squeezing the skin like this. We're going to look for symmetrical expansion. So Austin, can you take a nice deep breath in and out? Thumbs spread away from that spine equally on both sides. Next, I'm going to be taking a listen to his lung sounds. So I'm going to ask the patient to take a deep breath with his mouth open each time he feels my stethoscope on his back. Good. And again. Excellent. And again. So as I take a listen to the patient's breath sounds, I'm going to go back and forth at the same rib space so that I can get a good comparison. I'm listening for the effort that the patient has to have and any adventitious sounds like bronchi or wheezing or rales. Very good. Good. Typically there's going to be 8 spots on the back there, and then we're going to percuss by tapping the finger like this, and we're going to be listening for resonance. You find the space between the rib spaces and then tap like that, and you go back and forth in the same spots that you took the auscultation. Here you can find masses or fluid if there was not resonance in those areas. Another way to evaluate that is with bronchophony or egophony. So with bronchophony, I'm going to ask the patient to say 99, again, in those same spaces. Can you say 99?
99.
Good.
99. 99. 99. 99. 99. 99.
Last one.
99.
Very good. So with bronchophony, if the patient says 99 and it sounds different from side to side, that can indicate that there is fluid buildup or a mass that's creating a higher frequency of the tone. During the competency exam, I want you to choose either bronchophony or egophony, or something called whispered pectoraloquy or something like that. I don't usually do that one, but you can kind of do it with the other ones because that just means that they're whispering a word and you're seeing if it sounds the same on either side. With egophony, we're going to have the patient say E. If there's fluid or a mass in there, it will sound like A. And once you hear this once, you'll never forget it. So in the same spots, you would have the patient say E, E, and that's how you do that part. Now we're going to go over to the front of the chest here. And again, we're going to be looking for skin distribution here. It looks about even. There's no tenting of the skin. When we touch and palpate the skin, there's no crepitus, or when you feel it like Rice Krispies, if there is subcutaneous emphysema because of flu or air from under the lungs, if there's like a pneumothorax or something like that. So again, we're going to do the same thing, but here on the front of the chest. So we inspected, we palpated. Next, we're going to take a little listen here. On the front of the chest, there's 6 spots I want you to be taking a listen to. And the first one is at that second intercostal space around the midclavicular line. Take a deep breath in and out with your mouth open. The reason you have the patient breathe with their mouth open is because it causes the breath sound to be a lot louder, and you can take a better evaluation of any adventitious sounds. Wonderful. One more here. And the last one, right like that. Perfect. Good. Everything sounds equal from side to side, and now we're going to percuss. So again, same thing, back and forth. I'll be honest with you, doing it on the front of the chest, especially on women, you're not going to really hear a whole lot. It works a lot better on the back, but for the competency's sake, because Cheryl said it's important, so I think it's important, we're going to do percussion on both sides of the body. And then for skin turgor, again, we're going to pinch just below the clavicle here and watch if the skin returns quickly. If it's returns right away, that's normal. If it doesn't, that's called tenting, and that means the patient is dehydrated most likely. Now we're going to move on to the cardiac assessment. So we listened to the lung sounds, and now we're going to listen to the heart sounds. There's 5 places you're going to want to listen to, and you can remember this by remembering the term ape to man. So aortic, pulmonic, Erb's point, tricuspid, and mitral valve right here. So the first one is going to be at the second intercostal space at the midclavicular line, and then you can look in your book to see if those other points are. Where the mitral valve is where the point of maximal impulse should be, or PMI. If you feel here and you can't feel it very well, you can always ask your patient to lay down and turn to their left side. You don't have to do that. And you can feel it a little bit better, because when they turn, it really does bring the heart closer to the front of the chest. So first you're going to take a listen with the diaphragm. So if I tap over here, I don't hear anything. If I tap here, it's really loud. So you're going to listen to those places, and you're going to be assessing for rhythm, the strength of the beat, and then when we do this with the belt, you can assess for murmurs a little bit better, or thrills. So you're going to listen to those places, here, here, and here. Now, a common thing that I see, especially with neuro nurses, is when you're using the bell, a lot of nurses like to put it on the skin like that, and that just turns it into the diaphragm, because the patient's skin then is creating the diaphragm. So you want it to just be very light over the skin, and you're going to be able to get a much better effect. So again, aortic, pulmonic, Erb's point, tricuspid, and the mitral area. Since we're already have inspected the front and the back of the torso, we're going to jump into a skin inspection and the peripheral pulses. So to complete that exam, we're going to look at 3 spots on the scalp, assessing for distribution of hair, any mites or lice that might be in there. I sure hope he doesn't have any, but he doesn't. Everything looks really good, but there's 3 spots there. And then you're going to look at the arms, again, looking for even hair distribution. Right while you're here, you can feel for the brachial arteries, the radial arteries. You can feel for the carotid arteries here. You're going to be feeling the lower third, and you're going to do one side at a time. And you should know why that is. I want you to think about that. And the answer is because if I included both of them, then you wouldn't get blood supply to his brain and he might pass out. Never seen that happen, but supposedly it's true. While we're here, I'm going to put this bed at about a 45-degree angle and ask the patient to lay on back. And then I'm going to have a tangential light, and then if you could look that way. Austin, I'm going to be evaluating if he has any JVD or jugular venous distension here. He does not, so that's a very good thing. That goes along with our cardiac exam. You can sit however you're most comfortable. We're almost done here, so we're going to take a look here at the legs. Again, even distribution of skin tone and hair. The legs is going to be a little bit more interesting if you do have an abnormality for like peripheral.
This is called peripheral vascular disease.
Peripheral,
I apologize.
I don't know. Anyway, they're not getting good blood flow to their lower legs. They're not going to have a lot of hair growth, because it's kind of like watering a plant. If you don't water the plant dies. If you don't get blood down to the lower leg, the hair dies, and you won't have hair on that lower leg. We want to see if there's any edema here. And while we're down here looking at the lower leg, we can feel the popliteal pulses, which is right back here behind the knee. Of course, we're going to have the patient completely derobe, but for the purposes of this video, we're not going there. So we're going to go behind both, feel to see if they're symmetric, and then we're going to feel the post-tibial, which is going to be right here between the ankle bone and the Achilles tendon. And then I'm going to have you take off this shoe real fast, maybe. Don't get used to it. And this is your dorsalis pedis. Sometimes that one's kind of hard to find. So what you can also do is put your hand over the patient's foot. And of course, we'll have his sock off. But you can kind of start feeling where that might be, and you can narrow in where that is. If it is hard for you to find your patient's pulse, sometimes what's nice is to take a permanent marker and put an X on it so that the next person can find it a little bit easier. And of course, you're going to compare side to side. Lastly, for our peripheral pulses, can you wait back for a minute? I'm going to put your feet up. You do have your femoral pulse, which is right here in the groin area. You're going to wear gloves for that part of the exam, and then you're going to feel on both sides to make sure that those are equal. So we went from head to toe with skin inspection. We went through all the different pulses, and then we listened to the heart and lungs and evaluated those things. While you're going through this assessment, it's always a good idea to ask your patient some of the review of system questions, such as history, if they're having any issues at this time. I often ask the patient, have you noticed any additional swelling in your lower legs? Because everybody's made a little bit different. So I hope that's really helpful, and we'll continue with class here. Thanks.